Last slide that I'm going to go over is the most important slide of this thing. We are all getting old. We are all getting there. So please, let's all smile while we still have some teeth left. Okay, so thank you very much. And if you have any questions, I'll take them now. Yeah.
How do you see changes on X-ray in a patient of psoriatic arthritis? And the second question is, for how long can we give secukinumab Cosentyx?
The first question is that the X-ray changes we should be doing X-rays on these people, but we have to remember one thing, that the X-ray changes are seen normally after 3 to 4 years of the disease has already been present. Only if the disease is very active that we see X-ray changes within 6 months. So we should not be entirely dependent on the X-ray changes. But what we see are a little different from rheumatoid arthritis, because one, we see changes in the DIPs, and then we see not only the erosions, but we see extra bone formation. In rheumatoid arthritis, we see cysts, bone cyst, and erosions. But over here, we see big new bone formation. Number 2 question is, how long can we give it? Secukinumab was approved in 2015. So people have been on it for 3 years. So I can say the safety data that we have is for 3 years. But let me tell you, there are patients that I have on TNF inhibitors for 10 years. And if you watch them carefully, there's no reason why you should stop them. And yes, if you stop them, the disease will come back. But there are different ways of doing it. If people can't afford it, I stop it. I put them on oral DMARDs, some coverage with steroids, and put them back on it. Any other questions?
No issues with giving this drug?
I'm sorry, I can't hear you.
A treated case of hepatitis C. Is there any contraindication with this drug, or no issues?
If there's a hepatitis C has been treated, you can give it to them. And there is no case reports on it, but they have not put any kind of black box warning on it. So we can, I think if it's somebody treated, at least we give it. We just watch their SGPT, SGOT like every 2 months anyway. And if we see that titer is rising, we immediately go check the hepatitis C titers then. That's how we do. But don't be reluctant. I think the problem is we are all very scared. And since we have been using it for, like, as I said, 18 years, we are very comfortable with it. But I think you guys should be encouraged to start using it in your practices, or take, like we are always there for you guys. Like you guys are always there for us, right?
I'm Dr. Shogata Mirzada from Peshawar. I've just started one patient. She's in her 4 weeks, 300 milligram weekly, and now I'll switch her to 4 weekly dosage. But I'm afraid you scared me a lot. Because actually from the very beginning, I was requesting the Novartis people that kindly give me proper guidelines. I would confess that I have very little knowledge about all these things which you are telling us now. So I'm grateful to you, and I will request the Novartis people that please print a proper guidelines, and rather it should be documented, the baseline, and weekly or 4 weekly and 3 monthly. So thank you very much for that. I'm a bit worried about my patient now.
Actually, don't be worried. The thing is that I am the one who's actually not following the guidelines. Basically, it is supposed to be given every 1 week. But what happens in Pakistan, people cannot afford it. And I'm very careful about the affordability of our patients. So I don't do that. But your patient will be entirely fine. So don't worry about that. But I think I'm going to, hopefully, I'm thinking of publishing a guidelines for the treatment of psoriatic arthritis myself pretty soon. And it should be on Pakistan Society of Rheumatology website. So that should be there, yeah. So don't worry about your patient, yeah.
I am Dr. Fahim Shah from Fashin. Thank you very much for this nice presentation. My question is concerned about that the psoriasis can find at any age and any sex. So what you have to start of the age, any limits of the age, early age or in late age onset? And what about if lady can want to conceive during the treatment? So can we?
Okay. You have actually a few questions in there, and they're all good questions, relevant. It's not approved in pediatric use. Am I right? Yeah, it's not approved in pediatric usage so far, but the trials are underway. Number two, as long as you're an adult, you can be of any age and it can be given. Number two question was about pregnancy. It's the category B in pregnancy. Category C is safe, B is okay, and A is you cannot give it at all. So it is category B. It depends on the patient's condition. Like a lupus patient, if we have it and they're getting very sick, we continue TNF inhibitors because they are all category B. So if your patient is like very sick, has bad psoriatic arthritis and extreme flare of psoriasis, you can give it. There are no recommendations on them, but the company says the label is category B, which makes it not recommended, but it is safe. So I'm sorry, there's no, this is very individual basis. If you have the guts to use it, I think I will have no problem using it though. But then I've used it a lot already.
If I may make some comments.
Okay, the comments, anything else? Yes, ma'am.
Hi, I'm Kamal Mahmood. I'm a pediatric rheumatologist. I work in Alder Children's Hospital. I just wanted to make some comments. Obviously, beautiful presentation. First of all, somebody asked about use of secukinumab in pediatrics. Internationally, we're running a trial on secukinumab for the safety data in children. So I'm UK-wide principal investigator for secukinumab in psoriatic arthritis, and we are part of international studies. Same people who did SCULPTURE study and FUTURE study as well. So hopefully in next 3 to 4 years, we should have pediatric approval for secukinumab as well. Second comment, somebody asked about pregnancy. So most biologics are safe in pregnancy, but the most important thing to remember is unborn baby. So you can use anti-TNF in pregnancy without any harm, but you need to remember not to give any live vaccinations to newborn baby. DMARDs, most of them are safe, so both azathioprine and hydroxychloroquine are very safe. The last thing, a couple of more comments about, when you start people on things as significant as biologic, you need to choose the right patient, and then you should have right monitoring for them. So there's no point starting somebody on biologic and then if you don't have any monitoring data. So I suggest that use these platforms like Rheumatology Society and Dermatology Society and develop your registry data, especially at least for biologics and DMARD. So all over the world, in UK and America, people have biologic registries, and everybody across the country who anybody starts on biologic, you can develop simple forms and everybody can contribute to it. And only then you can have a nationwide data of how safe biologics are. You were very right in saying that we only have 3 to 4 year data on secukinumab and about 20 to 25 year data on anti-TNF, while in comparison to methotrexate, we have 50+ year data of safety, and MMF, we have 30 year plus data of safety on MMF. So I would suggest that these medications are used for acute remission, but at some point you need to take them off and give your patient a chance to fight with the disease and bring them off. So if you have someone who has a 2-year disease-free period, and I'm talking on behalf of pediatric practice, because in pediatrics there's more side effects involving immune system and sepsis and malignancies. So if you have anybody who's on these medication symptom-free for 2 years, that's your time and chance that you can catch the boat and try to take them off. But it is in the setting when they are already on adjunct therapy with a DMARD. So you don't want somebody in remission, then start them on DMARD to maintain therapy. They should always be on DMARD to begin with. I would just pass it to Dr. Sayed for some comments from her as well.
I just wanted to make a comment regarding the multidisciplinary teams. These drugs should not be given just by one physician or one pediatrician or one rheumatologist. And within your MDT team, the multidisciplinary team, I believe an orthopedic doctor should also be part of that team, because some of our patients come through them. So please be aware.
Combined clinics.
So the start of combined clinics for these biologics should be very important.
Thank you, and I will. I'm Amjad Khan, and I will just mention a few things. For the first presenter, very rightly chosen Cosentyx, because the other IL-17, one of them has got a side effect of suicide tendency. So that's very well done, and it's good to know that this is available in Pakistan, because obviously it's only 3-4 years old for psoriasis. So that's something I would mention. In UK, our practices, one I will just mention, there is National Institute of Clinical Excellence, NICE UK. If you Google, they have all these biologic guidelines regarding all the biologics which are approved in UK. So if you want to start somebody on and you want to know what before starting, before initiation, what sort of screening you need to do, what are the doses, what are the intervals of the monitoring, they are already freely available on internet. It's NICE, National Institute of Clinical Excellence. In UK, our recommendation, because obviously we have a pot of money from where all these are funded, is the patient should have failed 2 systemic agents, DMRDs or apremilast is one of them as well now, before considering any systemic agents. Up until recently, up until earlier this year, the NICE recommendation was for Cosentyx actually, 2 systemic agents, then 1 biologic agent failed, because this was second line. It's just being changed in July, I think, as a first line systemic agent. So please bear that in mind. And the guidelines are also available for our rheumatology colleagues or joint involvement on BSR, or British Society for Rheumatology website. Thank you.
Assalamu alaikum, I'm Badr Dhanani. Well, first of all, we truly are lucky that we've got secukinumab now, because I had been using etanercept for a very long time, and in fact I was probably one of the first people to use etanercept in this country. And my experience with that initially was very good, that it really worked, but for some reason after that we had treatment failures, and of course people they were totally non-responsive, and I eventually had to give it up. But I presume that in psoriatic arthritis it still does give some results, but in the dermatology part of it, it really did not. Second is that my thanks to the second speaker. I don't see her. Is she there? She's gone. Anyway, well, fine. My thanks to her that she's completely, warped up my concept of what arthritis and psoriasis used to be. We were taught in the last 30 years that it was a totally different concept. It was there that the radiological changes were different and all that. And today, what has been realigned is that anything that pains in psoriasis is psoriatic arthritis. So either we treat that as psoriatic arthritis or send and refer it to a rheumatologist to take care of that. So I think we'll have to actually, readjust the picture, because I'm sure all of my colleagues over here also had a different picture, that our textbooks used to say that psoriatic arthritis has a different radiological picture, and then you had some serological tests would come positive. But today, besides HLA-B27, I think everything